For those of you that don't know me, I'm Dr. Sandra Mudley. I'm the president of the College of Public Health Medicine. And I want to welcome everybody to our second Pholela Lecture. I think let me name some names. Fellows and Associates of the College of Public Health Medicine, the registrars that are here from Public Health Medicine and Occupational Medicine, colleagues from the Faculty of Public Health in the UK, and obviously the broader South African public health family. So just, I think most of you here are specialists and registrars, but just for those that are not, just to tell you a bit more about the college, it's one of 29 constituent colleges of the Colleges of Medicine of South Africa. And we are primarily responsible for the curriculum and assessment of specialists in public health medicine and occupational medicine. Some of the colleges, and not all of them, have eponymous lectures. And we decided last year to introduce one in the College of Public Health Medicine, and we took a decision to call it the Pholela Lecture. And to be selected to give one of these eponymous lectures is considered a tremendous honor. So the reason that we went with Pholela as the lecture, well, for those of you that don't know, the Pholela Community Health Center in KwaZulu-Natal is recognized globally as a site where the concept of community-orientated primary care was initiated in the 1940s and successfully implemented. And we, as the College of Public Health Medicine, consider the Pholela Health Center and their approach as a symbol for health system responsiveness to the needs of communities and based on a population health perspective. The first Pholela lecture was given by Professor Lillian Dudley and focused on how Pholela influenced community-based care in South Africa. And just before I came up, our awardee this year asked me how she was selected. So it's also quite a rigorous process. So we have a membership subcommittee that's tasked with identifying suitable candidates to deliver the lecture. And they submit that list to the Council of the College of Public Health Medicine. And then we then vote for our preferred candidate. And the candidate with the majority of votes is then submitted to the chairperson of the Education Committee of the Colleges of Medicine of South Africa for appointment to the lectureship. I think, let me also thank the chair of that subcommittee, Prof. Mary Kawanga, for leading the selection process this year, as well as organizing today's session. Unfortunately, she couldn't be at the conference, but we're very grateful for all of her help in sorting out the logistics for today. We've also structured this year's lecture slightly differently than last year, in that we've divided it into two. The first would be the lecture, and then the second half of the session will be a panel discussion where colleagues from the broader public health community respond to the lecture. And Professor Tracy Naledi will take over as soon as the Pholela lecture is complete. So my next task is to introduce this year's Pholela awardee. It's somebody that I know very well. We were in the same cohort of registrars in Gauteng. And you know, I think we all feel that ours was the best cohort, but I think evidence will prove that to be the fact. I wouldn't mention some of the names, but yeah, we've had a few PASA presidents, Colleges of Medicine of South Africa president, and now we have a Pholela awardee. Waasila and I also wrote our fellowship exams together in Bloemfontein in 2010, and we also served in leadership roles in PASA together. So it's a great honor for me to introduce her yeah, particularly special since we've come through the ranks together. Just a bit of background. She said to keep it very short. Dr. Waasila Jassat is a medical doctor and public health medicine specialist. She has a strong interest in using information for effective implementation of health programs. She is also passionate about knowledge translation. She currently works for Genesis Analytics and is seconded to the National Department of Health, where she provides technical support to the National TB program. From March 2020 to January 2023, she was employed by the National Institute of Communicable Diseases, where she established the DATCOV COVID hospital surveillance system, generating important analysis to support the national pandemic response. She was also the principal investigator on the largest longitudinal cohort study on long COVID in South Africa. She served in a number of advisory bodies and national task teams. In 2020, she was appointed to the National Advisory Group on Immunizations. She served, as I said, on the executive of PASA, including as secretary from 2010 to 2016. She's recently completed her PhD at the University of Western Cape, focusing on understanding the gap between health policy and its implementation. And she conducted a case study analysis of implementation of drug resistance TB decentralization in 2 provinces. So I think it's time to call her up to deliver the 2023 Pholela Lecture, Dr. Waasila Jassat.
Thank you so much. It's so good to see friendly faces out here today. It's such an honor to have been nominated to provide this lecture. Everyone is familiar with these images related to the father of modern epidemiology, John Snow, and his investigation of the cholera outbreak in London in 1854. And I think even now, simply put, our job is to gather data, to glean insights from those data, and to use them for action. And so I'm going to use this approach in sharing the story of DATCOV and why and how we collected the data, what we sought to learn from the data and how we shared it, and how it informed the COVID surveillance response. And I think I'll also try and reflect on what we did less well. So let me start the story on the 5th of March 2020, when the first case of SARS-CoV-2 was diagnosed in South Africa. While we had some time to prepare and learn from other countries' experiences, our surveillance arsenal, at least in the beginning, was limited. We had lab-based surveillance, and it collected data from all public and private laboratories around the country. And it was useful. And this is an example of the Omicron period and the percentage testing positive. And you can see the earlier rise in cases in the younger age group, a later peak in the oldest age group, and then a secondary peak in January in children of school-going ages when the schools reopened. So the case-based data was useful, although it was limited by testing challenges and the lack of uptake of testing. We also had surveillance later in 2020 from the Network for Genomic Surveillance in South Africa. And our scientists were at the forefront of describing emerging new variants and the characteristics, including transmissibility and immune evasion. In 2021, we also began doing surveillance of wastewater in a number of plants across the country. And these were also useful for early warnings and detection of resurgences, and also for tracking new variants. The South African MRC was conducting reporting on all-cause deaths, comparing the previous periods to the pandemic period. And we could see clearly the number of excess deaths during the pandemic wave. But all of these surveillance efforts were limited because they were not able to track who was experiencing severe outcomes, how many people, and what were their characteristics. And there was a real need for hospital surveillance for COVID-19, so we could describe the trends in admission and inform the resources we might need in our hospitals. We needed the data for informing the modeling of reproductive numbers and projections of resurgences. And later on also we realized we needed the data to inform us on understanding the characteristics of variants and whether new variants were associated with more or less severe disease. And so that's where we decided it was important to have hospital surveillance. But we were limited again because there were no national health or hospital information systems in the country. In the public sector, we have aggregate reporting on the district health information systems. The private hospital groups all have their own information systems. To different extents, they are digitized. And at NICD, there is surveillance for emerging diseases and respiratory infections. The notifiable medical conditions is useful, but also has limitations because it requires healthcare workers to notify, but we don't have much detail on outcomes. And then we have very good severe acute respiratory infection surveillance at the NICD that has been long-standing, but again, it's only sentinel and in about 16 public hospitals across the country. And so, Prof. Lucille Bloomberg had the vision to implement a surveillance system in hospitals. Within a week, in late March 2020, the DATCOV system went live, and we began implementing in the 14 designated public hospitals where COVID was being managed. The provinces started to see the value of this data and began implementing in other hospitals. The private sector came on board and started sharing the data, and the Western Cape government began sharing data from their information system. And so, unlike normal implementation, which is top-down and nationally sanctioned, here's a surveillance system and here's a memo to all the HODs to implement, this was really bottom-up. And it was through the value of seeing the surveillance in the hospitals that provinces started to roll out further. And eventually, in July that year, the NHC Tech took a decision to adopt DATCOV as a national hospital surveillance system for COVID-19. They supported the rollout in the provinces, and by September, when the deadline for implementation was reached, most hospitals were reporting. And actually, by early October, through a Global Fund grant, resources were placed in the form of data capturers in all public hospitals to support entry of data on DATCOV. And so by the end of when we were reporting COVID surveillance, we had 264 private and 406 public hospitals reporting data to DATCOV every day. So we had to be quite clear on what our purpose of the surveillance system was. And we knew it was about surveillance and not research. We also had to be mindful that, especially at the peaks of the waves, we were asking busy clinicians and data people in the hospitals to submit data every day, ongoing for over 2 years, and so we needed to keep it simple and short. And so we focused on the key demographic data, age, sex, and race. Were there presence of comorbidities? How were people treated? Particularly, did they need to receive oxygen or ventilation? Where were they treated? In general wards, high care, or ICU? And what were their outcomes? So other things, while they would have been nice to have, were just not within the arsenal that we were looking for reporting in the surveillance. So we left out things like symptoms, clinical data, laboratory investigations, complications, and treatment with antivirals and steroids. And absolutely they would have been useful, but I think our system would have been challenged by asking for very complex information from mostly data capturers to report. So we set up DATCOV as a web-based platform, and hospitals were provided access and given a rudimentary training because it was quite intuitive. And they submitted data daily on admission of the patient. They did daily updates on the patient's status and a longer discharge form with capturing more complete information about the hospital stay. So initially, we used that web-based platform, and the public hospitals were submitting data. But when we realized that the Western Cape and the private sector had their own information systems, we didn't want them to have to double capture data. And so we allowed for bulk import of their data. We specified the parameters, they created exports, and they shared data by APIs or secure folders. And we imported that data into the DATCOV system. So it was very important that that data was available to inform local action. And so on the platform, hospitals could download their own line list and have summaries of admissions. We shared a line list every day with provinces and with the National Department of Health Data Lake, as well as a Power BI summary. And this was important because managers need data for reporting. We also had a dashboard on the NICD website, and every week and every 2 weeks between waves, we shared a longer report analyzing hospital admissions. We also shared data globally with ICARIC and with WHO. And it was interesting that when they analyzed their data, over 50% of the global cohort of data analyzed came from South Africa because of our willingness to share our whole DATCOV data surveillance data, whereas in other countries they were sharing from smaller sites. So I think while we did well with sharing that data with those who needed it, when we shared the data with the public, I think it was less innovative and less appropriate for the way the public probably needs to engage with the data. And so our daily COVID stats maybe was not as effective. And it was up to other people who took the data, analyzed it, and repackaged it, and shared it on Twitter and social media. And it was the NICD data, but I think it was just able to engage people more. So I think we definitely could learn more from how we can use the data to share with the public and how we can think of appropriate mediums and platforms to share that data. So the DATCOV data was an important source of data for informing the national response. And particularly in the second and third waves, where we saw increased severity, high rates of admission and deaths, government had moved to higher levels of restriction. But in the fourth Omicron wave, when we reported a lower level of admissions, lower numbers of deaths, government never increased restrictions beyond level 1. We shared data with the South African COVID Modeling Consortium, and they were able to do projections of hospital admissions, and this informed the planning around the beds and ICU capacity we might need. So even though we were sharing that data and the modeling was being done and we were sharing this data in the media, we had briefings with the Ministerial Advisory Committee, the IMT, we did weekly reports to the IMT Hospital Readiness Group, I'm not sure that this translated into effective surge planning. And if I can share with you some data, some analysis we did after the second wave, compared to weeks where there were low numbers of national admission, under 3,500, in weeks when there were very high numbers of national admissions, over 8,000, people who were admitted in those weeks had a 24% higher risk of dying. And this really shows that our capacity during the peaks of the waves were really strained, and that perhaps we did not have enough surge capacity to cope with the demands during the peaks. One of the first questions we asked of our data was who were most at risk for COVID-19 severity. And we published this paper in the Lancet Global Health, and we showed, like it was being shown in other countries, that males, older individuals, people of color, and people with comorbidities like hypertension, diabetes, chronic cardiac and kidney disease, and cancers were at higher risk of dying of COVID-19. And in a South African context, it was also important to show that people with TB, current or past, and people with HIV had a moderately increased risk for mortality. Later on, we were able to look at the issue of HIV, and over the 5 waves, we compared case fatality ratios and the risk for mortality. And so what was interesting in red, you can see that the decrease in the Omicron waves of the case fatality ratio was more pronounced in HIV uninfected individuals. And so people who were with HIV were not as impacted or protected by vaccines and prior infection. And so then the risk for people living with HIV compared to those without HIV for mortality was 70% and 80% higher during the Omicron waves when they had been less high in the earlier waves. And so we engaged with this data with a non-communicable disease cluster at the National Department of Health. We did briefings with the Vaccine Ministerial Advisory Committee and the NDOH, and this data was used in vaccine prioritization. In the first general rollout of COVID vaccines, people over 60 were prioritized, which was in keeping with the data that the oldest were most at risk. Later on, people who were immunocompromised were offered an additional dose of COVID vaccine. And later, when we came to the question of vaccinating children under 12, the DATCOV data on the reduced or very low severity of disease amongst young children informed the intervention that only children who were at risk for severe disease, who had comorbidities, would be offered the vaccine. One of the gaps I feel in our understanding risks was women who were pregnant and the neonates that were born. And we had applied for funding in 2021 to do a study and obtain funding from the MRC, but because of delays in the funding, the study only started in October 2022 and is still not complete. And so the study aims to understand the effect of SARS-CoV-2 on pregnant women and the neonate, and we're doing the study in 14 public hospitals. So it's unfortunate that during the pandemic, we didn't have the data to understand what were the impacts on the pregnancy, on the neonate, but hopefully even when we do get this data in the next few months, it will inform our understanding. So another question that I had was, South Africa is known for its long-standing, persisting inequalities in health prevalence, disease prevalence, health outcomes, in access to healthcare, and in the quality of services that people receive based on your race and based on your socioeconomic status. And were these inequalities persisting during the pandemic? And so we know from our earlier analysis that people of color were at higher risk of dying compared to white people, and people admitted in the public sector were at higher risk of dying compared to people admitted in the private sector, suggesting, you know, the socioeconomic issue as well. So it was very interesting when we analyzed the data of the proportion of COVID admissions that were treated in ICU by race and health sector, that one thing we understand is that if you were in the private sector, you had a much higher chance of being treated in ICU, just because we know that there's greater capacity and resources for ICU in the private sector. But interestingly, people who were black had a lower, were treated in ICU in lower percentages in both the private sector and the public sector, despite them being at higher risk for severe disease and mortality. And so this was an interesting and very worrying finding. Did it suggest a racist kind of rationing of services provided to black people? Or did it suggest that, you know, black people were most often treated in rural public hospitals, district hospitals, where they didn't have access to ventilation, to ICU, and to referrals to higher level care? I mean, it raised more questions than it did answers, but one of the things we did was write a publication. We shared the op-eds in the media, which we wrote with Nicholas Crisp. And we also worked with the HSRC, funded by Gates, to host a series of workshops in the provinces where I first presented the data, and then it led to a day-long discussion on inequalities in South African health system. So the next question that emerged later in 2020 was, as new variants were emerging, what was the impact on the severity of disease? And so when we analyzed the data after the second wave, we found that compared to the first wave, people admitted in the beta wave had a 31% higher risk of dying. Similarly, in the Omicron wave, we began to report the decoupling of cases, admissions, and deaths for the first time. And our data analysis showed that compared to the Omicron wave, people admitted in the first, second, and third waves had a 2- to 3-fold higher risk of dying. And so I think this is where the South African scientists really shone. This real-time surveillance enabled rapid detection and characterization of these emerging variants for public health action. We held numerous media briefings to the MAC and the IMT. The National Variant Consortium was formed, and we met weekly for that entire year and a half to share our findings on the new variants and all the different aspects of its characteristics. And we also published a number of papers, and they were very highly cited, including policy citations. But the papers came later. Earlier, in the first few weeks of the Omicron wave, we were sharing rudimentary graphs that were showing that more children were being affected and admitted, and that disease was, by and large, less severe. Less people needed oxygen, less people needed ventilation, and mortality was lower. And we shared this information late November, early December with the international media, briefings to the Africa CDC and the WHO. We had weekly meetings with governments from the UK and the US, and we shared data with WHO, ISRIC, and many other international collaborators for joint analysis. This data was important for advocating around the unjustified imposition of travel bans against South Africa and other Southern African countries. And it was noted by the WHO at the International Health Regulations Emergency Committee, the concern at the reaction of parties in implementing blanket travel bans, which were not effective in suppressing international spread. Another important question I raised, which was not about publications, but about how our public sector was coping, was understanding the high mortality in some settings. And so we could see from the data that the case fatality ratio in the public sector was 26% and 19% in the private sector. And in some provinces, over 35% of Eastern Cape, KwaZulu-Natal, Limpopo, and Mpumalanga having particularly high case fatality ratios, while Northwest and Western Cape had low case fatality ratios. And even in the private sector, there were some differences, with the Eastern Cape and Limpopo having higher case fatality ratios than the other provinces. What was most alarming to me was that 12 districts had a case fatality ratio of over 30%, and 84 hospitals, public hospitals in South Africa, had a case fatality ratio of over 40% of all COVID admissions. And so we worked with the national IMT for hospital readiness. It was beyond the mandate of the NICD, but we felt that we needed to act. So we developed a tool, a qualitative survey of the hospital, and a quantitative record review of the deaths. We assembled teams across all provinces who did the data collection, and we revealed many factors that explained the high mortality. On the patient side, older age and comorbidities and people presenting late to hospital. But most concerning to us on the health system side, the lack of availability of beds, staff, oxygen, medicines, the long turnaround time for results, issues related to clinical management. Only 9% of people never received oxygen or steroids, and also the problems with escalation of care, including challenges with referrals and ambulance services. And I think ultimately the lack of a well-coordinated clinical governance system. So I think that, you know, what we did was we presented the data with the IMT with all the provinces, and we had the audit teams present the findings in provincial meetings. There was discussion on the remedial actions, but I'm not convinced about any concrete steps that were taken. And so I asked myself, what could we have done more than analyzing the data, developing a method to audit the hospitals with high mortality and presenting it back to the provinces? And, you know, I'm still not sure that enough was done to address these findings. Later on, I think we were confronted with a changing immunity landscape in South Africa, and we had to ask the questions of the data. So we were seeing that from studies that seroprevalence was increasing during the pandemic, with the latest estimates well over 90% of seroprevalence. And this was complex, heterogeneous immunity from prior infection and from vaccination. And so in our publication in late 2022, we linked our DATCOV hospital data to the national case line list and to the EVDS vaccine registry. And we reported that people with prior infection had a 60% lower chance of dying. People with partial vaccination had a 10% lower risk of dying. Full vaccination, a 40% lower risk, and people who had been boosted had a 60% lower risk of dying. So these were quite convincing evidence about the impact of vaccine, but it raised some important questions for me about where we could have done better. So we don't have a national unique identifier, and it was difficult to link between data sets, and so we had to do fuzzy probabilistic matching, which was not ideal. We could easily get access to the national case line list because that was an NICD surveillance system. It was more difficult to get access to the EVDS, and it was only in late 2022 that they were able to link the data. And there was some attempts to link the data with the Department of Home Affairs deaths line list to try and get a true reflection of the deaths from COVID-19. And I think it's quite interesting that even by the end of when COVID data was being reported, our colleagues at NICD never got access to the vaccine data system to allow for vaccine effectiveness studies. And so remember, this was in the era of the POPI Act being promulgated, and there were lots of sensitivities and concerns about the sharing of patient-level data, but I think there was a case to be made for the public health need for that data. I think the other issue that I have is that the HSRC and University of Johannesburg study was telling us about vaccine hesitancy, that people were mistrustful, that people had questions about the effectiveness of the vaccine. And here we had convincing data about the vaccine being effective, but I don't think we were sharing that data in a meaningful way. Groote Schuur did a good job of a simple infographic showing that those in hospital, in ICU, on ventilators were mostly those who were unvaccinated. And I think we should have translated that evidence a bit better for the public to be able to make informed decisions. So finally, it comes to the last question we have, and that was understanding the long-term impact of COVID-19. And here, our DATCOV data was not going to be sufficient to provide the evidence. So we obtained funding from Gates to do a longitudinal study of almost 5,000 participants who had COVID, hospitalized and non-hospitalized throughout the pandemic, and we followed them up for 12 months. And at 6 months, about 48% of people still had ongoing symptoms, and at 12 months, 42% of people still have ongoing persistent symptoms. The risk factors for long COVID are older age, female sex, white and Indian race, people with a greater number of acute COVID symptoms and people with more severe acute COVID disease. And interestingly, those infected in the Omicron wave had a lower chance of reporting long COVID than those in previous waves. So I think we were particularly successful in our advocacy and communication around long COVID. We set up a web page on the NICD website where we shared information and patient testimonials to provide guidance to people with long COVID because there was an absence of information. We published a few papers, including a comment I was asked to author in The Lancet, which recently appeared, about long COVID in low and middle income countries. We presented in the media and at conferences, and also on the NDOH clinical task team, we informed the development of long COVID guidelines and webinars aimed at healthcare worker training. We also worked with advocacy organizations to set up long COVID support groups. So where we are now, the Disaster Management Act has ended, and the WHO has declared COVID-19 to no longer be a public health emergency of international concern, and we have high seroprevalence in South Africa. But what does the future hold as we move towards endemicity? Will we continue to see the emergence of new Omicron subvariants, or will we see new variants that might have different characteristics? Will we see more resurgences? Will we move to seasonal disease? What will be the impact of waning immunity and co-infections with other viral pathogens? Will we get access to vaccine boosters in the future? And what of the access to antivirals and variant-specific vaccines in low and middle income countries? So let me reflect on some of the lessons that we learned. Number one is know your epidemic. You need agile surveillance systems, and at times you need to develop new surveillance systems to be able to answer the questions and provide an understanding of the pathogen, both in its short-term and long-term implications on individuals, on the health services, and on society. I think it's asking and answering the right questions is almost as important as having the data. Again, we needed to be flexible as we learned new things and new insights of COVID-19 emerged, and we needed to think ahead because answering these questions meant applying for funding, getting ethics and approvals, all within an epidemic context, and trying to set up studies to answer these questions. Collaboration was key, and I think it's important to reflect on the fact that public and private hospitals were reporting data to one system for 2.5 years of the pandemic, which has never before occurred. I think there were also really important collaborations between researchers, both locally and internationally, and between researchers and governments. And I think that was another important lesson, is that many countries face challenges at the interface of science and policy. In South Africa, we had some missteps, but by and large, I think specifically with regards to NICD and our mandate to do surveillance for infectious disease, I think we had a harmonious relationship in sharing data, in delivering joint press conferences and briefings, and in answering the questions that emerged. As I've shared with you, I think that we use platforms that we could to share data as much as possible, but perhaps we did less well in sharing data with the public, and maybe we had a greater role to play in addressing the misinformation that was rampant during the pandemic. And finally, in terms of data for advocacy, we used, Prof. Lucille and our team were very keen on identifying opportunities for sharing and advocating for public awareness so that people could understand that they were at risk for severe disease, for national response, for example, in requesting for schools to go back to in-person schooling, and for global understanding and solidarity in terms of the way we shared data on Omicron. And this took the shape of editorials in journals, op-eds in newsprints, media interviews, and briefings with leaders both locally and globally. And I think we forget what a powerful tool data is for advocacy. So finally, as we had ended our surveillance, our very intensive surveillance for COVID-19, we reflected a little bit on what we learned and what we needed to continue into the future. I think the collaboration between the public and private sectors, between laboratories, research organizations, and surveillance needs to continue and be strengthened. I think that some of what's come out of the COVID surveillance is that the NMC surveillance has been strengthened with hospitalization added. The National Department of Health have adopted the HPR number as a unique identifier to allow for continued patient care and for linkage of important public health data sets. And this year, the Digital Health Cluster at National Department of Health embarked on developing the electronic medical record for South Africa, and will be piloted earlier next year for the HIV and TB programs. And finally, in terms of pandemic preparedness, we showed that South Africa was an important node for surveillance in the global kind of management of the pandemic. We need to continue sharing data with our global counterparts, and we need to think about what all of this means for the surveillance that we implement in the National Public Health Institute for South Africa. I'd like to acknowledge all the many people who were supportive and of implementing the DATCOV, and on a personal note, all the people who have mentored me and guided me in my journey as a public health person, many of you sitting here today. During the pandemic, Prof. Lucille Bloomberg and Cheryl Cohen, Prof. Slim Karim, Shabir Mahdi, Glenda Gray, and so many people who made space for me, created opportunities for me, and mentored me. I think that I was uniquely placed to be able to see the ideal public health kind of work in action. Thank you so much.
Thank you very much, Waasila. Don't go. I think you really made our community really proud in terms of what you did, and your last comment around how you were right there in the front seat of watching public health actually emerging right in front of your eyes. I wish there were, I hope a lot of the students here in particular are seeing what is possible with public health. I'd like to invite our president, Dr. Mudli, to present you with the official Pholela Lecture certificate. Thank you very much. Please join, Waasila, if you may, after you've put your things down, join us here in the front seat to be part of the panel. We're going to have the panel, and I'll try and leave time for you to ask questions to Waasila and to the panel. As my president, Dr. Mudli, said, we wanted to have other reflections. You know, they often say that we speak in echo chambers, speaking to ourselves. So we thought it was important to have other people reflect on the presentation, and also integrate it with what we heard in the plenary this morning. So with that in mind, I'd like to invite my panel. And I'd like to start with Mr. Thomas Lamini, who is an epidemiologist and Deputy Director for Epidemiology and Research Directorate in the Department of Health in the Eastern Cape. Please join us, Mr. Thomas. A hand for Mr. Thomas, please. Mr. Thomas Lamini, thank you very much. If you can sit next to Waasila. And then I would like to invite Ms. Zimbini Madigiza, who is a Decano Atlantic Fellow for Health Equity in South Africa and a Community Outreach and Training Coordinator at the Rural Health Advocacy Project. Please join us, Zimbini. Thank you. Then I would like to invite Dr. Hlengiwe Gwebu. Have a seat. I'd like to invite Dr. Hlengiwe Gwebu from the Department of Public Health, and is the Acting Deputy Dean of Health Sciences at the University of Fort Hare. Welcome, Dr. Gwebu. Last but not least, I'd like to invite one of the godfathers. I said something inappropriate this morning. I won't say what I said, but the godfather of public health medicine, Dr. Peter Barron. He's a public health medicine who's really been around and at the University of the Witwatersrand School of Public Health. Thank you, Peter.
Can I stand?
So do you want to come speak here?
Yes.
Okay, you prefer to speak here. So maybe let me introduce what it is that you are going to be reflecting on. So, I mean, Waasila spoke very much around what happened at NICD. So we thought it might be important to have reflections from the province to say, when that landed on them, what happened? So Mr. Dlamini is going to tell us his story of being the person who actually received that data.
Thanks very much for inviting me to be part of the panel. I thought, let me share from our experience as people who were dealing with data. I have a team of 5 people who were dealing with data. Let me start by saying the beginning of the pandemic was very harsh on us. It was difficult, it was traumatic, especially that by that time, we did not have a good information management system for capturing cases, and we used to receive the spreadsheet from NICD on the cases, positive cases, and we'll also receive, a spreadsheet coming from the private sector, which is Ampath and Pathcare, and later we received data from these emerging private labs. So, but let me start by saying the coordination at the beginning was bad. We struggled. The lesson I learned from that was, if you don't have a good leadership or coordination, you struggle, beyond the difficulty which came from the pandemic. So we struggled with that. And the issue of relationship with stakeholders, we saw our stakeholders, with suspicions. You must understand that there was I don't want to call it moratorium, but there was an issue that it's only the minister who can communicate this type of information and so on. So we were worried that our stakeholders may communicate that information and find ourselves in trouble with the minister. But let me say that, in terms of using data, for the first time in my history as an epidemiologist, I saw, government being willing to use data. Forget about the beginning, where there were arguments about, the numbers, but with time, we started, moving away from being obsessed with numbers. There was an obsession with numbers. Let me give you an example. NICD will say to us, these are your numbers, which we have given to the minister. And we know in the province that we had a lot of, cases which come from private sector, which has not yet gone to NICD, and there will be those conflicts, about the report that we used to write every day, where they will ask, no, our numbers, we know you have underreported by 1,000 or 3,000 or whatever the number would be. But I must say that for the first time as government, we were very obsessed with numbers. We were very obsessed with evidence, which was coming from, from the pandemic. I think, let me just explain why we were obsessed with numbers. There was the contact tracing, which needed to happen. And you needed, the names, the address of the person. Now, you don't need it tomorrow. So you'd find that, we were, when you get the data, in the evening, when everybody is asleep, we are, pushing data to different districts to make sure that when they wake up in the morning, they do the contact tracing. So it was very stressful. And I wanted to imagine if we had a system which you don't need to push data. You had a system at your fingertips where you can, you know, from a district level or from a hospital level, wherever you are, you could simply, you know, log in and get all the information that you need. But the use of spreadsheet, yes, it worked, but we think we need a system, you know, which can accommodate things like contact tracing. You spoke about hospital data. You know, we need one system where you can go there. For example, if for example, as a case, I come to the hospital, it should not be something new where you still need to know where is the case coming from. It must be something that is already in the system. But unfortunately, we struggled. You must remember some of the people used to give us wrong data. I mean, wrong addresses, wrong cell phones. So it made contact tracing extremely difficult. But as I'm saying that as public sector, we were really obsessed with the issue of data. We had the interesting thing, we had a very good working relationship with private sector. As I was saying, I was receiving data from private sector, I was receiving data from NHLS, I was receiving data from NICD, and one of the unique thing that I think during the pandemic for the Eastern Cape, I still, you know, see it as a good practice. We could get data on healthcare workers who tested positive. And if you check our daily report, you will notice that, you know, the Eastern Cape was reporting on healthcare workers who tested positive. So that was one of the positive things. Unfortunately, at the beginning, that information from private sector, let me not say from the beginning, the private sector were not willing to tell us that this case is a healthcare worker. But most of the reports that we used to produce was healthcare worker in public sector. So what you see in terms of the healthcare workers who were infected, it was in public sector. We had a chunk of information that we did not have, which was reporting on healthcare workers in private sector. And another thing I want to say is that, which was part of the difficulty, we used to collect mortality data. So our hospitals and our districts used to send spreadsheets with the names of the people, the addresses, when did the person die, and all those things. So that in itself, can you imagine going back to my initial, you know, statement when I said, what if we had a very good surveillance system? There was no need for the flow of spreadsheets, you know, because when you deal with spreadsheets, sometimes something happened to the spreadsheet and you lose, you know, the information, or you find that the information is messed up. And we were merging what was coming from DATCOV and what was coming from the reports from the district. And another thing, the post-mortem tests that were done, you know, we used to merge all of these three mortality data sets and form one data set in terms of mortality. It was not perfect, but it was telling us the story that we needed to know. But of course, there are weaknesses which you can, you know, find because of that. Let me say this in terms of surveillance. I think the government did not do justice in terms of funding the development of the surveillance system. And we started getting a little bit of attention when we sat with NICD and we asked NICD to develop a surveillance system, which started in 2018, what is commonly known as NMC app, or Notifiable Medical Condition Surveillance System. It's commonly out there known as NMC app. And I wish we woke up earlier. Hence, there was a joint external evaluation where I was part of the national team. And, you know, when you also look at what we normally report to WHO in terms of the development of the core capacities, you will notice that it looked good. But, you know, the pandemic showed us that our surveillance system was not up to, you know, it was not the best. It had a lot of weaknesses. And it did not only evaluate indirectly our surveillance system, but also our health system. There were a lot of issues that came up during that. So I think for now, we are working on developing the integrated surveillance system, which we are hoping that we will have a good system to deal with pandemics in case there are. Let me say the last thing. The Port Health and Environmental Health, I would like to really appreciate what they were doing. They used to pick these cases at the port of entry, and they would report immediately. At night, you are asleep, you receive a message telling you about a vessel or a ship which came, and so many people look suspicious and calling the district here in Nelson Mandela Metro, and you'd find that there's a response even before you know, it becomes a problem. Let me lastly say, I'm leaving some of the stuffs. Waasila talked about a lot of stuff, but let me say that you know, we made some mistakes here and there. You know, for example, Waasila spoke about the facility-based case fatality rate. We used that information, Waasila. We didn't just look at the information and say, wow, that's beautiful. No, we used that information. There was a lot of training on case management, and we started that session with doctors and nurses, you know, on case management, and there were clinical audits, the right word, mortality audits, and so on and so on. So we started with the district that you highlighted, which was flagging, and we went to other districts, you know, to deal with the problem. Hence, when you begin to look at our mortality, it was no longer the way it was before. There was a decline in that. So let me thank you for allowing me to talk. I have a lot of things I can talk the whole day. Let me stop here. Okay. Thanks very much.
Thank you very much, Thomas. Thank you. Zimbini, you know, in the plenary session, we had Aneleka Yawa asked a very important question around where is the community. So can you come and share with us what you did, wherever you're comfortable? Do you want to sit there? Do you understand? Okay. Share with us some of the work that you did around translating more broadly, communicating with communities on what was going on around COVID.
All right, thank you. Molweni. I think, Prof. Tracy, COVID really gave communities a very big scare. It gave communities a very big scare. There were a lot of myths as to what is this thing. There were a lot of really resistance into realizing that COVID has really hit the communities, because I was working, so as Tracy said, I work for the Rural Health Advocacy Project, and when COVID hit in 2020, we were working with a community in Ngeleni in the Ortambo district. So it's deep in the rural area. So when we are like, okay, fine, what is happening now? There's COVID. Just to first raise awareness about the issue, about the pandemic.
They'll be like, no, that's a thing for the people living in Joburg, living in Gauteng, living in those places and stuff like that. So the most important thing that we had to do when it comes to translating research was to simplify the information as clear and as very effective as we can. We go stay with them, we make them understand as to what is COVID, what is happening, and all of those things. And remember, there were also the super spreader events. You know how rural communities are. Every weekend there's an event, right? So it had to come to a point of making a point that the communities take ownership of their health, right? They also come into play, into making a point that how do we then respond as a community? The communication channels with communities is they want to sit down with you and listen to you and be front of them, right? And when we were speaking of, contact, ungadibani kwabantu, and abantu bafuna usoloko bedibana, they want to be together all the time. We had to create communication channels that are going to be relevant to them. So if you're translating research, if you're translating any information that was coming up, we had to train the traditional leaders. We had to train the people that are trusted in the communities to be the ones who are actually disseminating information, right? So we had to come up with so many strategies and stuff like that. And the other thing that really helped was seeing communities now starting to understand and take ownership, because we are able to actually translate, research into communities. I think that point that Anele made of actually what do we do now with the information that we have. So I think I'm also challenging everyone to say, let's come up with action-based, implementable, research. How do we then do it and stuff like that, so that it does not just sit with the academias.
Thank you, Zimbini. And just to pick up from where Zimbini left off, Hlengiwe, even in the panel earlier, they were talking about, hey, you researchers are confusing us. This one says this works, this other one says no, it doesn't work. How are we supposed to know as policymakers, as community people, and some of the research being, as Zimbini was saying, difficult to understand? So as an academic, what are your reflections on that?
Thank you very much. And I'm so happy that you're relating this to the first session, because I really think it does really fit into that session like a glove. Maybe to then answer your question, I think what COVID did was to highlight an existing problem. And an existing problem is the lack of collaboration between us as researchers, the practitioners, the policymakers, and the communities. So I think even before we get to the point where we say findings are conflicting, I think it was Dr. Moketsi in the first session who said, there's just a lot of data. You people are publishing every day. There's so much, such that we don't know what to do with the data. So I think it's more of research translation. How do we make sense of what is out there, of what we produce? How do we as researchers bridge the gap to say what we are producing is actually going to be used and is heard in a language that is being understood by the people who are producing the data for. So I want to just take a step back, maybe, and say, when I started speaking, I said COVID highlighted an existing gap. I'll make an example of the work that I currently do. So I'm currently a co-PI in one of the studies under the Global Parenting Initiative, where we use an EPIS framework. So I'll use a framework because we're academics, we believe in using frameworks. So the EPIS framework basically stands for exploration, preparation, implementation, sustainability. So it talks, we've got an extended EPIS framework right now that explains clearly how to bring our partners, our stakeholders from the exploration phase to say whether it's an exploration of a research program, research idea, how do we bring in our communities, how do we sit together and understand? Because During exploration, that's where context comes in. That's where understanding of even some of the findings come in, because researchers know when they communicate findings, it doesn't go without the dynamics of research and limitations, right? There's also context in terms of research studies. There's also issues of methodologies that are being used. Sometimes it's also a matter of the sample size that was used, the analysis that was used. So even analyzing and interpreting those researches, when we bring our stakeholders in one place, they do understand the real interpretation, in all honesty, what the research findings mean. And researchers acknowledge the limitations of those researches. So I feel it was a lack of that built trust and relationship that should have happened from exploration to preparation. When we plan our implementation, whether it's research or research evidence-based programs, do we really bring them in to say, this is what we are planning to do? One of the lessons that we've learned is what we think really works is not what is readily accepted by communities. We sort of had to adapt most of our programs. We sort of had to go back to the drawing board after meeting with them. And it has been an iterative process. It hasn't been a straight path. So we've learned that it's not just a direct approach, and it's not just to say we've produced findings, take them, utilize them. This is very true. It's going to help. There's a lot of relationship building and trust that needs to happen. And because COVID happened and that wasn't there was a lot of fragmentation that was exposed. And I'm happy that Waasila in her presentation spoke a lot about research translation and collaboration, highlighted a lot of that to say, much as the data was there, the data wasn't conflicting, the data was produced, but it wasn't translated, it wasn't reflecting in the practice as they expected. So which means there's so much, it's not just a one line process, should I say, but it's a collaborative, multi-dimensional process that needs to come to play during implementation. And also when we plan, do we plan with sustainability in mind? What happens to the long term of it? What happens when we have another, I'm happy that you spoke about where we are right now. What happens now when we have another epidemic? Are we in a position where our relationships have been strengthened? Are we able to work together right now? Are our voices going to be heard? Because researchers on the one side, we're working very hard as well, doing a lot of important research, but was it getting to the other end? Was it being used, was it being taken up the way we would have loved to? So I think from the academic and research point of view, it's about how do we bridge the existing gaps, because they were existing before. The session that we had before just spoke about research in general, research translation, even without COVID. So in COVID it was worse, yes, but how do we address that to say, how do we bring in our stakeholders? How do we work together with them from the beginning so that we have very strong trusting relationships, that whenever another epidemic comes to play, we are able to sit down through a trusting relationship and speak about whether it's findings we are speaking about, or it's strategies, or it's research ideas. I think that is where I would actually bring it to say it's the fragmentation of our services. Thank you.
Thank you very much. So, Peter, you've been around. And I think I was so excited to hear Thomas say that our government was obsessed about data. I think all of us here, nerdies, were smiling, right? It was so nice to hear that our government was so responsive. And, you know, during COVID, people were saying, build back better. We're going to be better after COVID. And when I look around, I'm not so sure if we've taken up that opportunity to really leverage on the COVID. It seems like we've gone back to our old ways. I'm not so sure. So, I mean, Peter, what do you think are some opportunities that we have right now that could leverage on some of the things that have been spoken about to link to what Klengwe was saying around ensuring that actually we have a sustainable response?
Thanks very much. And firstly, I'd like to congratulate Waasila on a great presentation. And really, I want to build on the comments of the other panelists, and just to make some observations around COVID, and to talk a little bit more broadly than just COVID. I think COVID shines a light on the health system as a whole, and many of the problems that COVID brought up pertain to other areas of the health system, and I want to reflect on that mainly. And so Waasila spoke about inequity in how the disease presented and individual inequities with different case fatality rates. But there's broader inequities in the health system, and these have been known for a very long time. So there's inequities at a macro level on inputs, and rural districts generally are underfunded compared to urban districts. And nothing has been done about that since quite early after democracy. There was an initial move to reduce the inequities, and then it stopped. There's a lack of accountability to shift resources around generally. And then there's differences in outcomes, with the Western Cape generally doing better than the other provinces. But even within provinces, there's differences in outcomes. So caesarean section rates vary, just as a mundane example, quite considerably from one hospital to another. And interestingly, Waasila, one of the points you showed was that the Northwest Cape's fatality rate was lower even than the Western Cape in some cases. And there was no real reason for that, given the fact that the Northwest is fairly shambolic in terms of the overall. It would be interesting to know the reason for that. But that's just as an aside of public health, putting on my public health hat. Okay, so moving on then. The national and provincial departments of health generally don't have public health intelligence, and they don't plan to do things differently. Although the NAPISA, the National Public Health Institute of South Africa Act was enacted, I don't know, 4 or 5 years ago, it hasn't been implemented. And so provinces and national department don't benefit from this act. And it's not clear to me why it wasn't implemented. And there's a lack of accountability on the Department of Health. We take all the trouble to get something to go through Parliament, and then nothing happens with it. Maybe Leslie knows the answer to that. And so generally, one of the biggest things, and people have said this for years and years and years, that there's a lack of accountability in the system from top to bottom, from public health people working in clinics and facilities, all the way through to the minister and above. If you look at the annual reports and the annual plans of departments, it's just a bureaucratic mumbo-jumbo, the same old, business as usual. There's no innovation, there's no looking at planning and doing things differently. And I was thinking while I was sitting here that the public health community, of which I'm one, must be complicit for not making their voices a bit more, made a little bit loudly spoken. I think, you know, they're dependent on funding, so it's difficult to shout too loudly. Blah, blah, blah. Okay, moving on to data. Data linkages. Waasila says it's coming in 2024. Can we believe her? Because as far as I know, South Africa had the capability of doing data linkages around about 2010 or so, and it could have been, this whole system could have been in place in 2012. The Western Cape has already got almost an electronic medical record going. There's no reason why it couldn't have been done around the country. It's just a lack of accountability. And a mundane example, there's low-hanging fruit that could be done. So, for example, the Health Act gives the Department of Health the privilege or the accountability to get data from the private sector. They can ask them to give stuff. Even the most basic of information, like how many births are happening in the private sector, has not been asked for. So you can't pull these things together. So with it comes back, if there was a public health capability in these places, these things would have been in place. Then moving on to data at another level, the points made by Waasila around transparency and communication are critical to get the communities and population on board. Just so, for example, 2 examples came to mind. At the personal level, vaccine hesitancy was one of the outcomes of a lack of a clear communication strategy to get people to understand what it means. And at another level, NHI, without getting the population on board for NHI and let them understand in a coherent and easy way, it's unlikely that it's going to get far very quickly. And then moving down to local level, there's no reason why a facility can't make it clear to the local community what services are being rendered, when they're being rendered, and how long you're going to have to wait to get those services. I mean, it's sort of just basic kind of stuff. So I'm not going to go on and on because I could, but thank you very much for giving me the opportunity.
Thank you. So the challenges we stand back on us, and I think it's appropriate because now I'm going to ask for your reflections or any questions that you want to ask. You, are ready? Okay, 1, 2, 3, 4, 5. Let's take the first 5. Okay, you have the mic. Go ahead.
Okay, I'm going to do my job if I don't agitate just a little bit. Waasila, firstly, thank you for the incredible job that you did during COVID, keeping us all updated. Information is power, right? And thank you for your papers as well, which have probably opened up more questions, right? I think the most recent... Okay, so I must have spoken... So firstly, thanks for the work on COVID, I forget what to call it, COVID.gov. Anyway, but look, that was very useful. I think everybody used it. People from all sectors of society translated it. It was on Twitter everywhere. We knew what was happening, who was admitted where. But I think it's the things that we have to look at those reports now as we move forward. Right? I think your most recent paper on the age and race and socioeconomic status of COVID admissions within the public sector, right, should give us a window as to the level of inequity and the relationship that the broader population have with the health sector, right? So on the one, we saw that there was probably higher income groups that were admitted into public sector hospitals. Then when you put that next to excess death data, right, it raises a question that I hope the researchers can explore, is why poorer people didn't access healthcare services. You know, I doubt COVID was just a high income disease. And is there an issue around the responsiveness of the publicly funded system to the 80% of the population that it seeks to serve? And if your admission data is anything to go by, I think we have a lot more work to do in improving the responsiveness of the publicly funded system, let alone the private sector. The second question is around how far are we from Lydia and Leslie and others wrote a piece in the Daily Maverick in the early stages of the pandemic on universal admission criteria, so that we could determine where people were being admitted and whether we're using resources effectively. For all of the 2 years, we never got agreement on that. You know, so I took one of my daughters for a separate matter to a hospital in Johannesburg, and she still spent 3 days just going through the COVID stories and was admitted in the hospital. So how much capacity did we waste in the private sector by not having universal admission criteria? Thank you. Over.
Thank you. Let's take all 5 questions. Please, colleagues, don't be like Russell and make a speech. Please ask your question.
Thanks, colleagues. I'm not asking question, but I just want to share some of the experience in KZN, how we dealt with, my first name is Jablan, only one name, Mdebele. I'm just a civil society person. I just want to share the experience, how we manage it, especially the COVID in KZN. We were fortunate because we had a relationship with the university, especially UKZN, prior the COVID hitting us. So there's a project that we're driving. So Prof. Moshabela came in as a leader that will provide guidance in terms of what sort of strategy. But on top of that, we had registrars, public health registrars, that were posted within the department, that were meeting daily. Their role was they go and read papers and find out what are the new things that we can try. In the morning, then they share with us. We had academics. We had civil society rep into the daily committee that we are at, because they will tell us what's the community saying, what are the fears from the community. So it's just that COVID was overwhelming, but we try our best.
No, thank you. And so nice to see that our registrars were useful. There was a fourth here. Oh, third.
Thank you. Sure. Thank you so much for that presentation. It was quite insightful. I'm Sia Dlamini from the University of KwaZulu-Natal. I think I've got 3 issues that I want to raise as we look back at how we responded to the pandemic. And the first one is to what extent are we looking back and then evaluating some of the strategies that we used in our response? For example, to what extent were the lockdowns effective? Not only in addressing COVID, but also what are some of the spillover factors? How did it affect, other conditions, other areas of life, educational outcomes, for example, all of those things. Are we tracking that? Are we documenting that? And, if another pandemic comes again, are we going to apply the same strategies, or are we going to do something different? When it comes to issues of vaccine hesitancy, is it really vaccine hesitancy? Have we gone beyond just saying that we didn't communicate, effectively, or did we really address some of the concerns that the communities had? Is it not, perhaps are we terming vaccine hesitancy instead of vaccine caution, for example, linked to that? To what extent are we following up on the people that have gotten the vaccine? Are we documenting the effects of the vaccine, going forward? Do we have the same robust data collection methods that we used during, the height of a pandemic? And to what extent are we able to answer those questions going forward? And so I'm just concerned that, we're looking at this maybe from one side, but are we also looking at the other side and being critical to what we've been doing over the years, and what are the lessons that we're learning from that? Thank you.
Thank you very much. There was another hand. Where?
Yeah.
Okay, go for it.
Yeah. Thank you. My name is Kukule Tungubani. I'm a public health medicine registrar from UCT. I'm standing up to really reflect and applaud the College of Medicine for making the Pholela Lecture, and the reflections are very touching for me. I was, during the pandemic, the head of health at the Solidarity Fund, and I just want to reflect on the power of the use of data. And because I was interacting a lot with Waasila and many public health medicine registrars and specialists, to just say, we are always told that data is so poor, you can't use it, but look at what happened during the pandemic. The operational data and predictive modeling really helped us to first plan what exactly is going to be the response. We were able to raise money. So we used data for resource mobilization. The Solidarity Fund raised 4 billion rands to help the pandemic. And that would not have happened if there was not enough data to convince those businessmen, those countries that have a lot of money and that we're seeing the real mortality and the burden of the pandemic in South Africa. The second part was that using the data from the hospitals, from especially the DATCOV, and seeing data coming from public and private, which has never happened before. It really helped us to see what are the resource inequities in our health system. And the Solidarity Fund was then able to then come up with a project where we were actually procuring medical equipment for ICUs, for high care, for just diagnostics for the overflow during the surge times. And we were able to use the modeling consortiums for the different waves to be able to go ahead of the next wave to the actual right geolocations. And we could prioritize the provinces that were going to be more affected, and we could also prioritize the specific communities where they were completely left off, you know, not the ones that have the highest resources, but the ones that have the very least resources. And I believe, you know, in that strategy, just using data alone, we were able to strengthen the health system, hopefully trying to make the health system to be more resilient for the next pandemic. But more than anything, I really want to just thank the network of public health medicine, because without it, I don't even know. You know, sometimes you take certain roles and you say, oh, this is such a big risk, it's probably the death of my career. But because we had all these WhatsApp groups, you could ask questions. I could even text Prof. Slim from WhatsApp as if he's ever known me from anywhere. But just because, you know, we are in a pandemic and it's a public health emergency. So I just want to really recommend that, you know, we get this use of operational data and we get it published, and we don't lose some of the networks that were created at that time, to just get the information faster so that those who are interested to support, because a lot of people will phone, how do I support, what do I do? But because data was at our fingertips, and there were people who were very quick in analyzing it to see whether, is this real, is this fake, and what is happening within the profession. You know, you were dealing with scientists. Then we'll be able to say, no, that community needs more help than that other community. So I just want to see, maybe we should look at how can we, what can we sustain, what can we keep from the lessons during the pandemic. Thanks.
Viva public health, viva! Harsha, you have the last question.
Okay, thanks Tracy, and thanks everyone. I'm Harsha, affiliated with the PASA, Wits School of Public Health, and Takano. So congratulations, Waasila, that was a wonderful lecture, and thank you panelists for your great insights. I want to reflect on the issue of access to data. While we are developing these great surveillance systems, I just wonder, during the pandemic, under the Disaster Management Act, this actually superseded all other legislation in the country, even the POPI concerns, but the National Department of Health did not hear this, and we were stuck in a deadlock. We could not use public health intelligence to inform what we were doing at all the levels of the health system. So what are and what can we as a public health community be doing to address this now before we face another pandemic, and also to solve our day-to-day issues with public health intelligence? Thanks.
Thanks everyone for listening so attentively, and I hope you enjoyed the inputs from myself and the panel. And thanks again for the questions. Russell, we've had this conversation many times. But I think you highlight an important area. We were focused on hospital surveillance, and it always worried me that we had no idea what was happening to people who weren't coming to the hospital. And when we were looking at the excess deaths, reporting over 300,000 deaths, while we reported 100,000 confirmed hospital deaths, we knew that there was a big problem outside. And there were anecdotal reports of people driving around trying to get to a hospital, dying in ambulances and cars. So, you know, it goes to our preparedness and our surge capacity, the capacity of hospitals to cope with the numbers. It goes to community awareness of their own risk and how to present early and where to present. And I think that was a big failing in the pandemic. I mean, I think it's a shame on us that possibly 3 times more people died outside in their homes and didn't make it to hospital. We tried to do the linkage, as I said, with the Department of Home Affairs data, so we could get a good idea of, you know, who died, who were these excess deaths, were they likely, you know, COVID deaths, trying to link them to the case line list, but we know people didn't test. Trying to link them to the hospital line list, but we know people didn't make it to hospitals. So I think a better patient-level information system would help in the future. But I mean, I think that was a big shame and a big failing in our pandemic response. And with regards to the, private sector capacity and access, while 16% of people access the private sector, during COVID, half of the admissions were in the private sector and half were in the public sector. And so that shows the resource gap. It also shows that private sector had more resources to admit maybe milder patients, whereas the public sector was trained in admitting only the sickest patients at death's doorstep. Our audit revealed that over 50% of the people died within the first day or two of being admitted, of those that we audited. And so, I think certainly it was talked about in the beginning, the sharing of capacity between public and private sector. Some provinces managed to enact formal contracts, I think only the Western Cape, to access private sector beds. But it's something we should have pushed for and explored more because there was capacity that could have been used. But then where is that capacity? It probably would have helped urban settings, and those in the rural district areas would still have been in the same position, accessing hospitals that were ill-equipped to deal with severe COVID-19. I think with regards to the questions of, what we learned and have we reflected sufficiently, I know there were attempts to do after-action reviews by the World Health Organization, but I think we moved on too quickly. And I mean, just looking at what happened after COVID, we had a measles outbreak in the country, we had a cholera outbreak, and I don't think we did better. Not on the data side, not on the working between science and government and actions, not on communication with the public. And so it worries me that for all that I'm presenting about what worked so well in terms of all of these things, better data, better collaboration, we sort of unlearned all of that and weren't up to the test when the next two outbreaks hit. So I think, yeah, we do need to look at, did we sufficiently improve? Did we improve it just for COVID? Did we improve data just for COVID? Or did we sufficiently improve so that we have long-standing benefits for pandemic preparedness in the future? And I think also your questions around vaccine hesitancy, I think certainly there was a gap and a vacuum, and it was taken by those maliciously spreading misinformation. And the information was there, and as I said, maybe we didn't package it enough, and maybe we didn't find the right forums to communicate it in the way that it would translate. But I think more could have been done. Kuku, thanks for your reflections as well. And I think I didn't talk about that, but you're absolutely right. The power of data for resource mobilization, absolutely important as well. And Harsha, finally, to your question around data access, it can be depressing and frustrating, but I feel like we just have to push and explore the avenues that are available to us. And I'll give you an example. So I'm working in the TB cluster at the moment, and I've managed to get myself on the business team that leads the HIV and TB clusters in engaging with digital health on the EMR development. And there's a technical working group for HIV and TB data systems. And I've volunteered to lead the work stream looking at data access and data use. I think it's only when you're in those spaces that you can force the conversation. And if they still refuse, they have to document why, and you can kind of hold them against that. And so, I mean, the only thing I can say is there are processes. We have to be in the spaces where we can inform those processes. Thanks.
Thank you very much. I know there are other questions, but it's now lunchtime. So I think people can engage with panel members at the end, but I would like to give my panel one last opportunity to make closing remarks. We'll start with Peter. Peter says he doesn't want to say any more.
Okay, thank you so much. I just wanted to say I feel on a positive note, we are at a prime time where such conversations, there's so much appetite for evidence-based solution from the government side, from practitioner side, and from research side. And I think, such as Waasila said, if we don't translate that interest into actionable steps, we will still be here in 5 years' time, still talking about how, what worked and what didn't work during COVID. And yet there's been other sort of like conditions that we could have applied those lessons in. So I think the most important thing right now is how do we take this forward as a body? I'm happy with that PASA provided this platform, but how do we continue these conversations? Because here we've got everyone represented, everyone is here. All the stakeholders are here. We've got our community, we've got our activists, we've got our researchers, practitioners, the government is here. How do we continue these conversations to make sure that we do better next time? Yeah, thank you.
All right, Nkosi kakhulu. I think one of the most important things is how do we make it a point we have good coordination of the available data, the available resources? How do we actually strengthen our governance? You know, how do we make it a point that we have very good leadership? You know, because when you're talking of accountability, we need people that are going to be able to answer to the communities, right? So I think we really need to look at how do we actually strengthen governance. You know, how do we utilize the existing structures like your clinic committees that could serve as a link, you know, into that simplifying the data. We sit down with them, and then how do we utilize, how do we make use of the anecdotal information, because there was a lot of anecdotal information that was actually coming from the communities, and then how was that included, right, and then used. And then I think lastly, one of the most important things is that why are we doing what we're doing? What is the real problem that we are trying to address, right? We want people to make informed choices. So I think for me, if we could have a very strengthened governance, I think we could actually have improved leadership. Thank you.
Thanks again. I think in terms of the relationship, we have to be intentional. We have to find a way to build these relationships. It does not help for us to mourn about these things and we do nothing. So from both government and private sector, NGOs, universities, we need to find a way to build that relationship. And secondly, I personally think that the issue of access to data comes when there is a relationship. So which means we must build, we must roof our house before the rain comes. So if we wait until the rain comes, that's when we look at each other with suspicious eyes. So, and during the pandemic, we have seen it that we can work together. For example, I was supported by the NGOs, you know, in terms of data management. I had somebody who was coming from the NGO who was dealing with data. I didn't have time to deal with data, you know. So that's what I'm trying to say. But the issue of us sustaining that relationship, I think we are not doing well. And we must admit that. So which means we need, you know, to find a way to sustain that relationship.
Waasila doesn't want to say anything. So, I mean, I think the panel, thank you very much to my panelists. And I think it showed on one hand, I think Waasila's really wonderful keynote showed us what is possible, what it is that we as a community can do. And many of us who in public health, and I think the colleague from KZN spoke about it, many of us were in the trenches and many of us actually had doors open that possibly were not open before. So I think it showed us what's possible. But Peter also didn't want to say anything, but he also said an important thing. He said, if it's not going to happen, we are complicit. Are we making enough noise? And I think we've seen that we can make a change. And I think I challenge all of us in the room to take up, the challenge has been placed by all our panelists to say, what is it that we are going to do? I mean, Mr. Dlamini said that it's possible. It is up to all of us. It's not one person, but it's all of us. So thank you very much. And one last round of applause for everybody. Thank you.